Good morning, everyone, and welcome to the Fall 2020 Medical Series. Want to thank all of the returning OLLI members for signing on to another year of OLLI and attending the classes. I would also like to thank all of the new members who've joined OLLI and transitioned to us during this time of COVID and are watching on Zoom for the first time. Also, this year, we're trying something new. We're using YouTube Live to stream these to people who don't have Zoom. So welcome to all those guests that we have out there. And if you enjoyed this presentation, we hope you join us and join OLLI and see all of the other classes. There are a number of different ways to watch this. This is a open to the public presentation. So what that means is anyone in the public can see this. You don't have to be an OLLI member. So we provide the Zoom method for those OLLI members who can access the link. We also are streaming this on YouTube Live, like I talked about. This lecture will be recorded and it's available on the distance learning part of the OLLI webpage. If you're interested in getting additional information on the classes that are open to the public, if you go to the OLLI webpage at olli.fullerton.edu, that'll bring you to the main Fullerton OLLI webpage. On there, there's a welcome button. If you click on the welcome, it'll bring you all sorts of information about classes in OLLI. If you click on the free open to the public courses, it'll give you a PDF presentation with all of the different courses we'll be offering this semester. Okay, so today we have Dr. Hyder Jamal. He's a gastroenterologist at St. Jude's. He's been involved in extensive drug trials in the treatment of esophagitis, excuse my pronunciation, bowel disease, precancer of the esophagus, and liver diseases. These diseases are increasing as the population ages and dietary changes, antibiotic use, and obesity become more prevalent. So Dr. Jamal, welcome. And if you'd like to unmute yourself and go ahead and share your screen.
So this is a new format for all of us. Normally when I make presentations, I'm kind of moving around, and so now I'm going to be confined to a chair as I talk to you guys. Virtual audience. I think it's a new experience for all of us. So I was given the topic of discussing gastrointestinal cancers. It's a very large topic and involves lots of different organ systems. I chose 4 of the common ones and specifically chose the cancers that are seen more as we get older. So that's a common theme of these cancers. All these cancers increase as we get older. So what are those 4 cancers that I chose? It's esophageal cancer, stomach cancer, pancreatic cancer, and colon cancer. So going from top to bottom, right? So that's our agenda today, to discuss those 4 cancers. And we can entertain questions after the end of each of the cancer discussion. I'm going to talk generally about the cancer and the organ in the first part of the presentation, and then take you through the common symptoms. How do we diagnose them? And then what are the usual treatments and prognosis for that? And then we'll stop for questions for a short time and then move on to the next cancer, okay? All right, so we will get started. Vicky, very graciously, our office manager, is helping me out, my audiovisual challenges. All right, so don't mind the slight cutoff on the slides. I tried to make the slides very large, and I think in that effort, some of it got cut off a little bit, but that's okay. This is just a jumping point for the discussion we're going to have. And the main message is going to be evident on that. So the first cancer, as you can see, is esophageal cancer that we're talking about. The importance of that is esophageal cancer seems to be increasing in the last 10, 15 years. And perhaps 16,000 Americans die each year because of esophageal cancer. It is more common. It is more common in men compared to women. Doesn't mean that women don't get esophageal cancer, but it's more common in men than women. And it'll be evident as we look at the reasons why people get cancer of the esophagus. Broadly speaking, there are two main kinds of esophageal cancers. The first one's called squamous cell cancer, and the second one's called the adenocarcinoma. We're primarily going to talk about the adenocarcinoma, but I just want to briefly mention a few things about squamous cell cancer. Squamous cell cancer is worldwide more common than adenocarcinoma, but in the United States, adenocarcinoma is more common. Squamous cell cancer does tend to affect patients more in the Asian countries, in China, in India, and Iran. It is thought to be linked to ingesting hotter liquids in the diet more. Perhaps food content such as nitrates may be involved in that. Chronic injury due to caustic ingestion in childhood can also lead to this particular kind of cancer. There's also risk in patients who drink significant amount of alcohol or smoke. And here in this slide, you can see a slight comparison between the two. This side is the squamous cell cancer, and this is the adenocarcinoma. The striking thing that you can see is that adenocarcinoma is linked more to something called Barrett's esophagus, and we're going to talk about this in the upcoming slides in a minute. Reflux of acid symptoms and being overweight. On the other hand, squamous cell cancer is more linked to socioeconomic condition, caustic injury to the esophagus, radiation therapy, etc. So that's the comparison between the two. So now let's focus on the adenocarcinoma. The risk factors, generally speaking, are smoking, alcohol intake, reflux of acid disease. And who doesn't have reflux of acid disease, right? It's very, very common. In some people, perhaps as many as 1 out of 8 people who have reflux of acid will develop something called Barrett's esophagus. Barrett's esophagus means there's a permanent change in the lining of the esophagus, transformed into looking differently under the microscope because of chronic exposure of the acid. And of course, obesity is a risk factor in that too. So if you think about, as we said earlier, 16,000 people die of esophageal cancer, and the incidence seems to be increasing with time. Unfortunately, survival rates for esophageal cancers have not improved dramatically in the last 20 years or so, despite all these improvements that we have in terms of diagnosis and management. Going to the next slide. So what can you do preemptively to try and lower your risk for esophageal cancer? Well, you got to do the opposite of the things that cause esophageal cancer, right? So you should treat your GERD symptoms better, maintain a healthier body weight, and improve dietary habits. And if there is the presence of Barrett's esophagus, then that should be monitored and treated as per the protocol that we're going to discuss next. So going back for a second, what exactly is Barrett's esophagus? This is an endoscopic picture of the esophagus with the camera looking down into the esophagus. The paler surface is normal, and the salmon-colored reddish surface is the change in the esophagus lining called Barrett's esophagus. So if I were to biopsy the red or the darker portion of the esophagus under the microscope, that lining will look like it's coming from the intestines. So if I didn't tell my pathologist where I biopsied, he's going to say, well, you biopsied in the intestines, right? I said, no, I biopsied in the esophagus. So then he'll say, well, then this is Barrett's esophagus. The way to think about this is that we all came from a single cell, and those cells differentiated into different organs. But those cells still retain some capability to transform into something else. And the nearest thing in evolution in the esophagus, to the esophagus, is the intestines. And so it still retains the capacity to transform into its, biological evolutionary brother, right? And this is in the face of irritation or a noxious stimulus that this happens. It didn't happen voluntarily, it happened involuntarily, right? Why is this important? Because this surface now is an unstable surface, and that can transform into cancer. So once we recognize this as a problem, now we know what to watch out for, and therefore we can develop a means to intervene and reverse this change, therefore lowering the risk for cancer, right? So that's the strategy. And that brings us to a technique called radiofrequency ablation that we started several years ago at St. Jude Hospital. And this is a way of burning off that intestinal lining or Barrett's esophagus of endoscopically, and sort of kill that surface and let the normal surface grow back into that area, and therefore lowering the risk for cancer. So that's an aggressive preemptive strategy. Not let this happen, reverse it before it happens. And this is just a cartoonish description of how we do that. We attach the ablation electrode to the scope, or separately, we can put this in and we can emit this heat energy that then kills off that surface, and then we scrape it off. So that's that. Now, if we couldn't prevent the formation of cancer and we found it later on, then we are back to treating this cancer, which I told you earlier that does not have a very good prognosis. Here I'd like to introduce you to a concept of TNM, which is the way we stage cancers in the intestinal tract, okay? T stands for tumor, N stands for lymph node or node, and M stands for metastases or lesions going further away. And that's how we classify most cancers in the GI tract. What is the T score, what is the N score, and what is the M score? And that gives us an idea which strategy to use for which particular cancer. So obviously, if it's an early cancer, which would be a T1N0, meaning there's no lymph nodes involved and it's just confined to the surface of the esophagus, then sometimes a technique called endoscopic mucosal resection is enough. Meaning you can go with a scope and raise that surface up or suction it up and just cut off that lining and then repair that space. And that, if it hasn't gotten any deeper than that, then that's enough therapy. Anything deeper than that will require surgery. Obviously, surgery on the esophagus is no fun time. It's a pretty difficult, tough surgery. But that is the best thing to do for deeper cancers. Once the cancer goes further into the lymph nodes or to the distant area, then doing the surgery doesn't really improve the prognosis, and then you're left with chemotherapy or radiation therapy, which does not yield as good a results as a surgery would, and therefore the survival rates for cancer for advanced disease are quite dismal. Okay, so how do we find these cancers? Usually, patient may present with a symptom such as discomfort, trouble in swallowing, weight loss, bleeding, and then an endoscope and a biopsy will make a diagnosis. If the diagnosis is confirmed, then the next step is either to do a CT scan of the chest and abdomen or a PET scan to see if there's a distant lesion or not. And then we can triage into one of these three modalities of treatment, okay? So now we're moving to stomach cancer. So moving down the intestinal tract. So stomach cancer is also prevalent more in the Asian and South Asian countries. It is still present in the United States, but not as common. 95% of all stomach cancers are what we call, again, adenocarcinomas. It is an older person's disease. It's unusual for cancers to present before the age of 40, and it is at its highest rate in the 70s, age 70s. Men tend to get this more than women. Up to 21,000 patients may be diagnosed in the United States per year with stomach cancer, about 10,000 deaths from that. Before the 1930s, stomach cancer was at a higher rate in the United States. Since then, the rates have fallen. We think it has to do with a few things. Number one was the advent of the refrigerator. And the refrigerator did a few things. People did not use as much food preservatives or salt preservatives in meats, and more fresh vegetables and fruits were available because of that. Second change was the change in diet, which is more plant and vegetable based compared to just meat. And the third biggest reason why the rates of stomach cancers have decreased is the discovery of the Helicobacter pylori, which is a bacteria that lives in the stomach lining and is involved in a lot of the cancers. And figuring that out and treating that with antibiotics has helped us also lower the rates of cancer. Other reasons for stomach cancer is presence of chronic gastritis, which means anything that causes chronic inflammation in the stomach lining can lead to instability of that lining and an eventual transformation to cancer. And so that's a pathway of cancer, gastritis to metaplasia to cancer. And therefore, our hopes always are, when we do endoscope and do biopsies, is to try and pick these earlier signs of cancer and therefore able to influence the outcome in the future. Other potential reasons include presence of nitrates in the diet, smoking, previous history of stomach surgery, such as something called Billroth 1 and Billroth 2, which are surgeries that take part of the stomach out, but then they connect it to a later part of the intestines. Unfortunately, that causes bile that is present in the small intestine to wash back into the stomach and can also cause chronic irritation. Same point, chronic inflammation. There is also some genetic predispositions. That's a much rarer issue, but there are certain genetic mutations that also increase your risk for stomach cancer. So let's think about the opposite. Well, what can we do to make that less of a possibility? Then yes, more fresh fruits and vegetables, healthy diet, not gaining weight, not smoking, and vitamin C, which is present in a lot of the citrus fruits, is actually protective for stomach cancers. Okay. Just a little brief slide to show the structure of the stomach. Stomach is, we think about it as a dumb, large bag that is meant to dump food into, but it is a complicated organ. And it is composed of several segments. There are areas, the top part of the stomach, where you churn the food and make it smaller and mix it with pepsin and acid to sort of break down the tough portions of the food, which will then eventually help the food get digested in the small intestine. Pretty much all of our food is digested in the small intestine. The top part, the stomach, is a conduit to make it improve efficiently absorb the food, and the colon is the waste part of that. The digestion occurs actually in the middle part of the intestines, which is a small intestine. It does have numerous glands, acid production, hormones, transporter molecules. So it has multiple functions. And anybody who's had surgery on the stomach and has lost part of their stomach knows the importance after you eat, how much more harder it is to tolerate food when you don't have part of your stomach. most patients with stomach cancer really don't have very many symptoms, but they could, depending on the location of the cancer. There are two main types of cancers, the ones that present on the top part of the stomach and the ones that present on the lower part of the stomach. And therefore, the symptoms associated with are slightly different. The ones on the top part might cause hiccuping for unknown reason, significant increase in reflux of acid, could cause abdominal pain, and weight loss. The lower part can present also with similar symptoms, except bleeding sometimes can be an early manifestation of that because they may ulcerate and cause bleeding. So decreasing the risk of cancer, as we talked about, improvement in diet, eradication of the H. pylori bacteria, avoid drugs that cause ulceration, and be able to pick up on biopsies early changes that might be leading to cancer. Okay. A brief word about this bacteria H. pylori that we've been talking about. For a long time, nobody really believed a bacteria could live in the stomach lining because that has acid and it's a pretty tough environment. And the first time this was described, people thought this was an anomaly and maybe not a true finding. But over the years, we found out that, yes, this particular bacteria can survive in the acid environment and actually thrives in that environment. It is not necessary that anybody who has the H. pylori bacteria will have a problem. In fact, majority of the people don't have any issues or symptoms because of this bacteria. But some people will get gastric ulcers, some people will get duodenal ulcers, some people will get gastritis, and yes, some people will get gastric cancer because of H. pylori. So should we test everybody for H. pylori? That's not the usual recommendation. If I took 100 people off the street and checked everybody for it, I would find 10 out of 100 will be positive. But if I went to perhaps South America or Far East Asia, and if I took the same 100 number of people off the street, I might find 90 people with H. pylori. So where you live also matters in terms of prevalence of this bacteria. So immediately you can see the connection between the rates of cancer in those countries versus United States. But just because you have it doesn't mean it has to be treated. If you have the risk factors, family history, presence of ulcers, then yes, checking for the H. pylori makes sense, and then eradicating improves those particular outcomes. So those are the symptoms. This is the bacteria. And then, so how do we make a diagnosis for stomach cancer? We may put a camera down the mouth and take a look inside. And if you see an abnormality, we may look at it and biopsy it. And what are those abnormalities look like? So on the top part, you have a sort of a hard, firm, sort of a protuberant lesion that's abnormal in the lining of the stomach. And so we would biopsy it. And then there's the excavating ulcer, that the deep white base is the ulcer crater. But in fact, the best place to biopsy this is around the edges, because that's where the cancer cells are proliferating and moving to the side. All right. So we talked about the risk factors. These are some of the other ones. Interestingly enough, blood type A is a risk factor for stomach cancer, not because of the blood type itself causes cancer, but because that blood type may be associated with certain genetic anomalies that may lead to that. Socioeconomic factors, presence of polyps, and the H. pylori infection. So now we found the cancer in the person, and so what do? As we said, adenocarcinoma is the main kind. Really, for most of the cancers, the idea is to sort of figure out whether or not this is an operable cancer or not. If it's operable, then that's the best thing to do. If it's not, then chemo and radiation therapy are the next options. Unfortunately, radiation and chemotherapy are not very effective for stomach cancers. If we found the stomach cancer at stage 1, then the prognosis is pretty good, because that means the lesion was confined in the top lining of the stomach and it can be removed. And the prognosis of 5-year survival is between 80 and 90%. If it's stage 2, then the prognosis goes down to 30 to 50% survival rate. And lower than that, stage 3 and 4, prognosis dramatically drops down to 20% and maybe even as low as 5% 5-year survival rate. Unfortunately, 2/3 of the time, by the time we have a diagnosis of stomach cancer, those patients are not considered operable. And even when we push the limit and operate on those cancers, half the time the stomach cancer recurs and comes back. And that's because this is a very immunogenically active region, so it's very easy for cancer cells to spread through the lymph nodes and surrounding circulation. Okay. Generally speaking, there can be cancers. Most commonly, it's actually lymphomas that can occur in the small intestine. And then there are rarer cancers, including stromal tumors, neuroendocrine tumors, that can occur also in the small intestine. The presentation quite often is very difficult, meaning there aren't very many symptoms. If it's a hormone-producing cancer, then it can present with symptoms such as flushing or diarrhea or weight loss. Because it's a deep organ, it's hard to find those cancers. There's a few ways we can figure those out. One of them is something called a capsule endoscopy, in which you can swallow a robotic capsule that can send pictures, almost like a Mars rover from inside. And then if it looks abnormal, then we have to go with a really long scope to try and get to that spot and get a biopsy. And then based on what the pathology is, then the treatment options are different. All right, so now we're moving on to pancreatic cancer. This is the anatomy, sort of abbreviated anatomy with the other organs removed. You can see the relationship of the pancreas with the small intestine. The bigger part of the pancreas is called the head of the pancreas, and the lower or the last part of that is called the tail of the pancreas. The head of the pancreas is sort of cupped around the first part of the small intestine, or the duodenum is right next to it. And it shares a similar opening to the bile duct that's coming from the liver and the gallbladder. And so the bile duct sort of traverses the pancreas and then opens into the small intestine. This relationship is important to remember because the presentation of the cancer is based on where and how it's located, okay? So November is a pancreatic cancer month, if nobody knew that. So it's coming up. And it is, becoming more common. 56,000 people will be diagnosed with pancreatic cancer each year, and about 34,000 deaths in the country because of that. Once again, the most common kind of the pancreatic cancer, there's numerous kinds of pancreatic cancers. The most common and lethal type is the adenocarcinoma. Unfortunately, there aren't very early signs for pancreatic cancer, so there's no surveillance or screening really for pancreatic cancer. Quite often, it will present with abdominal pain, sort of a non-specific discomfort. Pain could sort of traverse the abdomen and be felt in the back sometimes, meaning almost like a through and through knife-like pain. Weight loss is another common presentation, and then jaundice, because of that bile duct that traverses the pancreas. Sometimes it will close up the bile duct, causing bile to back up and causing jaundice. So those are the top 3 or so most common types of presentations. Alcohol use, tobacco use, obesity, and diabetes, and family history of pancreatic cancers are some of the common risk factors for pancreatic cancer. So as we said, yellowness of the eyes, unexplained pain, new onset diabetes suddenly for person was fine and within a month suddenly has significant diabetes. That could be some of the presentation. In terms of work environment, could there be a relationship between exposure to things? There is possibility. Exposure to chemicals in the rubber industry, petrochemical industries, and some people think maybe even hairdressers might be more susceptible because of the aerosolized spray that they use. So there could be certain environmental risk factors that lead to that. This is once again the relationship with a little bit more detail. So mass in the head of the pancreas can cause jaundice because of obstructing the bile duct. Because large blood vessels are located right behind the pancreas, they can be spread into those large blood vessels. And once that is involved, then the person becomes inoperable for surgery. And I mentioned this because that's helpful to sort of figuring out why do we decide to do surgery on somebody and why do we not? Because spread to the local large blood vessels can basically mean a poor survival. This is a CAT scan view of the pancreatic cancer. Think about CAT scan as somebody slicing the body longitudinally and then you're looking from the top down on it. So you're sort of cutting through each of the organs. Right in the middle of that picture, I think there's little arrows that are going to it, little fuzzy, sort of irregular middle part of that is the cancer. And you can see that leaf-like structure of the pancreas with the body and tail of the pancreas going towards the right of the screen. So that's what it looks like when there's a large tumor in the pancreas on a CAT scan, which is quite often the way we make a diagnosis. For smaller lesions that we don't know what it might be, because it can also be benign lesions in the pancreas, right? We can biopsy those lesions, and quite often you don't have to go from the outside, you can actually biopsy from the inside. And that's done through a special kind of scope called an endoscopic ultrasound attached to a scope. And you can see beyond the wall of the intestines. Remember that diagram I showed you with the pancreas cupped with a small intestine right next to it? So if you can bring the scope in that small intestine part and can look behind the wall with an ultrasound, you can find the lesion and you can put a little needle through the wall and get a sample of that, okay? So that's like being in a room but have the ability to look behind the wall in the next room and be able to put a needle through the wall and get a tissue out. And that can also help us in the diagnosis. So the purpose of doing the CAT scan and the endoscopic ultrasound is trying to figure out if somebody is operable or not, because operating and removing it is the best chance of curing the lesion. Unfortunately, most patients are not curable, and 5-year survival rates for pancreatic cancer remain dismal. So as we said, you can, by clinical history, presentation, ultrasound, CT scan, we try and figure out if somebody is resectable or not. If they're unresectable lesion on a scan, then a biopsy confirms it, then you can go on to chemotherapy or radiation therapy.
Okay, Claire, go ahead and ask your question.
I thought pancreatic cancer was like within weeks you died if you found out that you had it. A 5-year rate sounds really long, actually. But didn't it used to be that nobody ever survived it?
Right, so 5-year survival is like 5%. And that's how we measure survival rates on cancers. You're right, the survivals are not usually 5. That's why most people don't make it to 5 years. That's why it's a 5% rate of survival. And maybe weeks might be a little too fast, could be anywhere between 3 to 9 months on advanced cancers. Cancers that are operated on, of course, would have better prognosis. And that's why some people do survive 1 year, 2 year, 3 year. Still only 5% survive 5 years. Some of the older data was corrupted by the fact that, you know, a lot of the other kinds of cancers are in there lumped in there too. So not all pancreatic cancers, remember I said, are adenocarcinomas. We're talking about the 95% of the cancers which are adenocarcinomas. There are also other lesions or cancers of the pancreas that are not as aggressive.
Okay, Jim Monroe, you had a question?
Yeah, there's been some discussion about development of blood tests that could spot the pancreatic cancers much, much earlier in their processes. Are some researchers making real progress on that, or is that mostly the news?
Yeah, so I think the attempt is to find genetic abnormalities that might predict a cancer in somebody. We're still not there because most people don't have genetic mutations. Some do. The question is what to do if you find those genetic abnormalities. You can't operate on them. They don't have a lesion yet because otherwise you would have picked it up on a CAT scan, right? So they haven't made the cancer yet, but they're susceptible to it. So what do you do with them? Do you radiate them with a CT scan every 3 months? One idea is if you find the high risk genetic mutations, then to do what we call that endoscopic ultrasound that we were talking about, to do that maybe every 6 months or so, or an MRI scan. The problem is if you find a pancreatic cancer, quite often it's still too late by the time you detect it. I'll give you an example of mine. I had a patient many years ago who presented with liver test abnormality and sort of a vague pain. Nothing picked up on the CT scan and the MRI scan. But the presentation was suspicious enough that I was able to convince the surgeon that there is a cancer there. We just can't see it on the MRI scan. So he took her to the surgery and called me from the OR, say, absolutely, yes, we found it. There was a small lesion on the backside of the pancreas. We took it out, we cleaned it up. We're really happy with the surgery. Unfortunately, that patient still died within 1.5 years. So because by the time the cancer occurs, it's already sent its cells to the surrounding lymph nodes and blood vessels, and recurrence happens fairly quickly. So that's why there is no true surveillance or screening for these cancers, trying to preempt and try and prevent the cancer from occurring. Colon cancer is somewhat preventable, right? And the good old colonoscopy that everybody loves actually helps prevent colon cancer and saves lives. Incidence of colorectal cancer is actually decreasing in the United States, and we think primarily it's because of screening colonoscopies. So that's one good news. Some of that is also because of healthier diet and living by the general population. The lifetime risk of getting colon cancer in the United States is 6%, okay? And 5-year survival for colon cancer overall is about 65% compared to, remember, 5% for pancreatic cancer. It also depends on the stage of the disease. If you find early cancer, once again from a colonoscopy, stage 1, 93% survival rate. Stage 2 is 80%. Stage 3 is still not bad, it's 70% or more. But if you get stage 4, meaning it's now gone to distant areas, then it's 8% or less survival rate. When we do find colon cancer in somebody, then 40% of the time it is a localized cancer, meaning it's still in the local area and it's very operable. 36% of the time, it's gone to a regional lymph node, just a close by lymph nodes, still able to clean that out and get that stage 2 and 3 survival rates. 20% of the time, by the time you find somebody's cancer, because now they're obstructed, they've lost weight, they're bleeding, it's an advanced stage of cancer, that's 20% of the time, that's the way people present. And the most common areas that the cancer goes to is the lungs or the liver, because that's the area that drains that area. So as I said, the incidence of cancer is actually decreasing in the United States because of that reason. However, there's one subset of population that it actually is increasing. And we're not sure why that is, and that's actually in a younger population. Patients between the age of 20 and 50, the rate of cancer is increasing about 1.5% every year. So this is somewhat of a strange phenomenon. We're not sure what the reasons for that are yet, but that has prompted some movement towards lowering the age for colon cancer screening from 50 to maybe 45. And maybe 40 for higher risk population groups such as African Americans tend to get earlier colon cancer at a more advanced stage. The precursor lesion to colon cancer is a colon polyp. And colon polyp, I'm just going to skip forward for a second. Colon polyp is the precursor to colon cancer, and that's what you find either through a stool test to look for microscopic blood or from a colonoscopy. And if you remove that polyp, you have prevented that polyp from transforming into cancer. And therefore, it is both a screening examination as well as intervention for prevention of cancer. Not all polyps are the same. Some polyps, most polyps are what we call adenomas or tubular adenomas that carry a risk for cancer, but it's not inevitable that it would become cancer. As a general principle, the larger the polyp, the more number of polyps there are, the higher risk for cancer there is. So polyps that are more than 1 centimeter in size carry a larger potential for cancer. In addition, the pathology under the microscope can also sort of guide us what the risk for cancer might be. As we get older, the risk for forming polyps also increases. So at age 50, if our risk was 30%, so if there's nothing going on with you and you had a colonoscopy at age 50, you got a 30% chance that we'll find a polyp. If you never had an examination and you reached the age of 60 and we did a colonoscopy, you got a 50% chance that we'll find a polyp. If you raise the age of 70 and we did a colonoscopy, there's a upward of 65 to 70% chance that we will find. So it is age related, the formation of polyp. And the sequence of events is, normal to polyp to advanced polyp to dysplasia to cancer. So depending on where we find the lesion in its progression is what determines prognosis. If we missed doing screening and we didn't, do the examination and now somebody presents with pain or bleeding, it kind of looks like this now. It's sort of a circumferential lesion with some ulceration in the middle. And if you biopsied it, we will find cancer. And if you biopsied it, now we want to stage cancer. Remember we talked about the TNM before, the staging method? And that's kind of what it means. How deep has the cancer gone into the lining of the colon, to the lymph node surrounding, or to a distant organ? And that's what determines prognosis in the future. Remember we said from 90% to 8% depending on the stage of cancer. So similar options. If we miss the polyp, now it's a cancer, our options, best options, do surgery. Chemotherapy does work for colon cancer. Radiation therapy is more used for rectal cancers or cancers that are located on the lower end of the colon. And so if we go to the anatomy of the colon, these are some of the parts of the colon to remember. The bottommost part of the colon is called the rectum. Then you have the sigmoid colon as we're going up, then the descending colon. The middle part of the colon is a transverse colon, and then it goes down into what we call the ascending colon. And then the first part of the colon is called the cecum, which is where the appendix is attached. And if you go further up, then we're going to enter the small intestine, okay? So what are the risk factors for colon cancer? You've guessed it, poor diet, smoking, obesity, alcohol use. Those are all the risk factors, and genetics, of course, family history. Those are the risk factors for colon cancer. Symptoms for colon cancer may be none to sort of fatigue, anemia, rectal bleeding, persistent abdominal discomfort. The lower the cancer is, the more chance that it will present with change in the shape of the stool. I see patients a lot of times, they, notice a change in the shape of the stool. Most often it's because of a hemorrhoid or a diverticulosis of the colon, but that's one of the symptoms to keep in mind. Color of the stool, quite often people get hung up on. It's most often not related to a problem. And I tell my patients there's only a few colors I'm interested in. Number one is red. Well, then there's blood, right? Number two, it's black because there's blood coming from the top end. Or number three, it's pale white. And that's usually because of an obstruction of the bile duct because bile is not getting into the small intestine. Pretty much any other color I'm not really interested in because that's Gatorade or some food dye or something else that makes a different color. Okay. So when should people start screening or looking for polyps? The current recommendations are age 50, but as I said to you earlier that, maybe we should be doing it earlier than that, especially for certain populations, but that's the current recommendation. And of course, if you find the polyps at the polyp stage without any cancer in it, then the survival is 100% because you prevented cancer from happening. Okay, so these are the treatment. If you found the cancer at different stages, as I mentioned, the best step really is to do surgery. And if surgery is not an option, then chemo and radiation therapy. Of course, it also depends on the ability of the patient to tolerate chemo radiation therapy. So that has to do with the performance status. If the person is in a very poor health, then chemo and radiation therapy are likely not to be very conducive for them. These are survival rates that we're talking about. Once again, that TNM classification or staging of the disease, and 5-year survival is based on that. For stage 4 disease, if it's a really late diagnosis, then if they have poor performance status, then it is not recommended to put the patient through treatment, and overall survival rates are very, very low. If they have good performance status, even though they have stage 4 disease, and it's potentially removable or resectable lesions in the lungs or the liver, then that should be taken out, and then chemo and radiation therapy should be done. If the distant lesions are not resectable, meaning there's so many lesions in the liver, you can't remove them all, then just doing chemo and or what we call immunotherapy, that's a new treatment these days, that's another option. Survival for the patient depends, as we said, on the stage of the disease. Some tumors are more aggressive than the others, so the type of the cancer makes a difference, what interventions we chose, what is the performance status of the patient, and whether or not they're able to, participate in clinical trials. That's another potential factor. So multiple reasons determine which patient survives how long. So this is just sort of a way to think about, when to do screening for somebody. So bottom line is, if you have family history of colon cancer, if you have any symptoms, or you reach the age of 50, talk to your primary doctor and do your examinations. So can you, bring some advocacy to screening and surveillance for colon cancer? Absolutely, because screening saves lives, and removing any barriers to continued screening for seniors is something that that is advisable. There is this arbitrary age that Medicare has set up as 78, 75, that perhaps screening is no longer useful after that. But really what they're saying is that after that, we'd like not to pay for it anymore. It doesn't mean you cannot get colon cancer after that. The longer you live, remember I showed you that the chance of forming polyps increases as you get older. So realistically, the answer to is, when should I stop screening? Well, when is it that you don't really care about having cancer anymore, right? That's the age when you stop screening. So be proactive about these screening protocols. They do save lives. I'm going to end here with a true-false question for colon cancer, but the answer is circled already. Is colorectal cancer the second leading cancer killer? The answer is yes. Does colon cancer affect both men and women? The answer is yes. Colorectal cancer often starts with no symptoms. Remember we said it could be no symptoms at all, or there could be symptoms, but it doesn't necessarily have to have a symptom. And that's why screening is important. Does screening help prevent colon cancer? The answer is yes.
We'd like to thank you, Dr. Jamal, for presenting today. It was very interesting. There are some comments about very interesting and thank you in the chat.
Pleasure.
So